I'm going to do the review part first because it shouldn't take so long and then go back. So I was going to record it separately, but I didn't get a chance yesterday. It's been one of those everything that can go wrong will go wrong days for the last couple of days. So without any more editorializing about that, I will proceed to start the review. Let me take a look. It's here. There's search results. So as I'm scrolling through, I think there's around 50 questions about this. It, I think most of the questions probably point toward more the antibiotic aspect of things, but there are a few questions from the epidemiology and basically how infectious diseases do their damage and the way that they're spread and those types of things that are there. So there's effectively it's for this textbook. There's two chapters, 10 and 11. For if you, and I would certainly take a look at the Nestor PowerPoint 16, 19, and 20 because I think they're all relevant to this particular topic. Because Nestor, at least the first one is disease and host or infectious agents and host interactions, and then the epidemiology is separate. So and I used to say this. I don't know why students have had trouble. That's why I've decided to put it online and deal with it a little differently. Was because we're doing the review. Glad you could drop by. Where are your glasses?
I don't know, I just decided to go blind
Yeah,
today.
you look like you're squinting away. All right. I only can identify people what they typically look like. It's not being critical. I mean, I'm just so used to seeing seeing people in one way and not the other way. Just me. Okay, moving on. So to preface it again, so I'm trying to go. I do what I always do is to go through these questions. So the first thing is to understand how bacteria do their damage, toxins. Okay, the distinction is exo versus endotoxins. Exotoxins are any bacteria, gram positives or gram negatives. Gram negatives only are endotoxins because it's inherently part of their structure. So an endotoxin has to be that lipid A portion. So if a question asks about endotoxin, it's got to be a gram negative agent to start with, period. They all can make exotoxins. So exotoxins can affect the blood, hemotoxins affect the nervous system, like tetanus toxin, neurotoxins. There's a variety of different agents. Some of them are more dramatic than others, to tell you the truth. So some can be as, I hate to say innocent, but as relatively, self-limiting. So the last couple of days, like food poisoning. Okay, all of those are part of it. Okay, some of times the toxins or their agents produce an immunologic response. That's where streptococcus comes in, as you will see over time. That's more of the one where the immune system. So the toxins are primary damage. The secondary damage is generally immunological. The endotoxin of things of gram-negative rods, like E. coli or Proteus or those guys, Enterobacter, Klebsiella, are much more likely to be. They really act more immunologically than not because it's such a toxin that your system provides. Only the gram negatives. It's really more of an immunologic response. So I don't know if you can characterize it as primary or secondary. Then you get, and one thing the students, at least over the X number of years I've been doing it, have had some difficulty with is being able to identify, when things are direct or indirect with regard. When you talk about damage, direct means the toxin, indirect would be the immune system. When you're talking about spread of disease, direct is the person next to you coughing, and you're in such close proximity that you get whatever they're coughing out. Okay, and that's being respiratory in nature. Indirect is their coughing, some droplets get on, maybe from the previous class, get on where you're sitting on the top of the table or the counter, and you put your hand in and touch your face. Okay, so indirect means there has been an intermediary, typically a fomite, an inanimate object, a desk, a cell phone, a chair, uh, you know something, a plate. Pick one. Okay. So that's the big distinction. Whether when we talk about spread of disease, it have to be right next to you, basically, or in close contact with you. Certainly, somebody touching you, intimate contact with body fluids, whether they kiss you or they have sexual intercourse, whatever, doesn't matter. Okay, they're all in the same ballpark. Okay, so when something comes from, it's indirect if it comes from the food supply, for instance. And this is maybe the most common type of contamination we see in restaurants, is when somebody, either because of not observing proper hygiene, or they don't even know that they're sick. That's the chi-chi's one. You end up with that. So that's coming out of that. And then epidemiological definitions are important. Endemic is something that's always with us. It's constantly prevalent. It's constantly around in a particular area. Everything is area dependent. So we would have endemic diseases that we have around here in effectively a temperate zone would be different than they would have in a tropical zone, for instance, and certainly different than they would have in a much colder environment. You know, if you're close to the Arctic Circle, for instance. And it doesn't change what's endemic. Epidemic means there's a greater number of people getting sick from it. Pandemic means effectively it has spread sufficiently to cross a substantial barrier. Read that as an ocean. It's gone from continent to continent. It doesn't really describe or implicate the severity of the condition or what it's caused. It doesn't mean it's respiratory. It doesn't mean it's sexually transmitted. It doesn't mean it's foodborne. It just means, we're looking more at the statistical basis of it. So we look for things like that. That's why incidence, the number of new cases in a particular region over a period of time, is so important, because we basically are tracking: is it increasing or is it decreasing? If it starts to go up and all of a sudden levels and starts to go down, now we're getting, for whatever we're doing, we're getting a handle on it. Think of it that way. All right. Definitions again are part of this as well, and certainly the most important one when it comes to, when we talk about the antibacterial or antimicrobial unit, is antibiotics. It's a substance that's naturally produced by microorganisms that can either destroy or inhibit the growth cycle of other microorganisms. It's got to be a microbe attacking a microbe with some naturally produced product. When we play with it in the laboratory, now we have something that's semi-synthetic. We have a natural, so it's a semi-synthetic or modified antibiotic. Okay. And basically, other than the ones like typical penicillin or basic streptomycin, until we start tinkering with it, or basic cephalosporin, what they call first generation, everything else is basically semi synthetic in nature. So that's something. The most important antibiotic drug agents that we have in our arsenal are bactericidal. That's such an important distinction. That's the single, to me, other than the culture and sensitivity telling you what works. The next decision is, are they allergic to it? And if so, or if not, is it bactericidal or bacteriostatic? And then you look at the rest of the picture. If I choose this bactericidal agent, is it going to have some adverse effect based on their medical condition, on their medications they take, that type of a thing? But that's really you want to grab those first and then the bacteria. So the difference between cidal and static: one kills, one inhibits the cycle, just like the definition of antibiotics. That wasn't me, Dingy. I thought I turned mine off. The other important notes when we're looking at antibiosis are things like safety margin and therapeutic index. A therapeutic index is very simple. Whether it's a ratio in the therapeutic index or an absolute value in the safety margin, it's all the same thing. It's, is it more likely to hurt the microbe than the host? That's the whole idea. That's what's, is it more likely to kill, more selectively toxic, more toxic to the microbe than to the host? That's the absolute thing like that. So selective toxicity and therapeutic index are talking about the same thing as a safety margin for the most part. When we talk about half-life, now we're talking about the body's ability to deal with anything that's put into it, any prescription, non-prescription, any agent that they come in contact with, how rapidly your body can break it down. The word that we use is metabolize. It doesn't indicate that it's going to not have any effect or that the breakdown products are not going to have any effect. We call those active metabolites. But if whatever that initial thing, let's say you got a prescription for ampicillin, how long it took your body to break that down in some way, shape, or form, half of that dosage is the half life. And that's a really good indicator about how long between doses, how frequently you have to take it. And that's really important because today compliance is everything. It's, it's, it's not enough to prescribe something, and particularly for folks in nursing, it's very important to educate. Say, listen, you need to take this. We're going to make sure you take this. You only have to take it twice a day. Not hard to do. Once a day is even better. And that was always the advantage of the Z-Pack. Compliance, compliance, compliance. When something you have to take 4 times a day, we all, I just get so tired of it myself. It's like, well, I got to take more pills. I have one prescription. I've got to take 3 pills in the morning and 3 pills in the evening. I don't want to do it. They're horse pills. They're big. So, and believe me, as you get older, what the hell difference does it make? But that's the way it works. So that's the half-life nugget about that. The other nugget is adverse effects. Read that as side effects versus allergies. Allergies are specifically related to an untoward or unexpected response by your immune system, typically indicates that it's gone over the top. That's what an allergic response is. They can both be lethal. People make that mistake. You can die from side effects. I mean, even severe diarrhea and vomiting, that could get an elderly person or a baby, big trouble that are there. So they're not necessarily, if you want to paint with a broad brush or allergic response, it's not always more severe. It might be just a rash, just stop taking it, that are there. Okay. The headache is something, it's to me, that a lot of times, to me, I think it's really underlying it is gastrointestinal. Some of it just people find certain. I have a lot of medications that I think if you're prone to headaches, certain medicines lead to that, but it's not an allergic response. It's definitely due to the action of your immune system, and it's not about time either. They can manifest. An allergic response can take days to manifest itself. You were just talking about MADS. You did the immune. There's like all types of hypersensitivity. There's acute, immediate, delayed reaction hypersensitivities. Then there's cellular based immunity, all of which, like the TB test, takes 48 to 72 hours. If you respond when they do the TB test and you respond right away, it doesn't mean you have a bad reaction. It means you're allergic to what they call PPD, purified protein derivative. So that's the way you distinguish those kinds. So that's not certainly not life threatening. That's why you use a teeny tiny amount subdermally under your skin. Just saying. The biggest single problem with antibiotics, GI, GI, GI. The same thing. Oh, I have indigestion. Oh, I have vomiting. Oh, I have diarrhea. Oh, I don't feel right. Oh, I can't eat anything. All of that's gastrointestinal. The big underlying problem with that is broad spectrum antibiotics can clobber the normal flora and lead to things like C. diff, particularly. That's really how they work. Not a whole lot of between that. I do the categories. I'm mostly about categories when it comes to identifying the particular antibiotic. So know the cell wall antibiotics, penicillins, cephalosporins, vancomycin. There's a couple of those oddballs, the carbapenems that are there. Know the, how shall I say, know the uh, protein synthesis, ribosomal based antibiotics. They impact it in some way, shape, or form. So generically, I just call them protein synthesis. Whether it's the macrolides, which is erythromycin in the Z-bag, or streptomycin. And remember that category of aminoglycosides, streptomycin, gentamicin, which is great for, and really one of the better agents that we have for Pseudomonas, which is hard to treat, that's really the one that's considered bactericidal. There's a couple of newer ones like that Sinercid, which is a combination of two that technically are bacteriostatic and made in the laboratory that magically become bactericidal. So those are agents, tetracyclines. Their target protein synthesis. Their problem is the ability to leach calcium out of what we call hard tissues. That particularly affects teeth, baby teeth, and has impact down the road. So it really really impacts what your teeth are going to look like and the fact that you have. And that's really limited them. And they discovered because they were giving it to everybody back in the day when it really became popular in the mid 50s, that type of thing. So antibiotics were always kind of like looking for the better mousetrap. You know, that's the way it was. Oh, then it's the next best thing. We'll use it for everything. And even when CPRO came out, which is just this wonderful agent, and and fabulous against gram negatives, they marketed it about being useful against Staph aureus and strep pyogenes. So you could treat it for strep throat, you could treat it for routine staph infection and gram negatives, and you could treat people who are allergic to penicillin. And it's bactericidal. Wonder drug. Trouble was that even though it attacks staph and strep in the laboratory in culture and sensitivity, what we call in vitro in the test tube, it didn't work for real in us. Just the way it works. Okay. The other categories of impact, combination sulfates. That's that folic acid inhibitors. So that's another one of those wonderfully selective. It's like having a cell wall. Cell wall we don't have, so cell wall agents typically don't affect us as much, other than allergies, because being a byproduct mostly of fungi and mold, which we do have allergies to, and they were used extensively. Those kinds of things. That's why a lot of people will. It's interesting. Historically, they used to give penicillin and mix it with Novocaine. The name for Novocaine was Procaine penicillin. People say, "Oh, am I going to get a shot of Novocaine?" We hardly use it anymore. It goes away so fast. Okay. A lot of people who thought they were allergic to penicillin were really allergic to Novocaine, and now we use different agents that are in that category. They're there. The most common one used is called lidocaine, because it takes a lot longer for your body to break it down. It has to do with the chemical linkage and the enzymes that break it down. If I know a lot about anything, it's local anesthetics. Having given thousands of injections, 90% of my surgeries are done for local. So all of those are part of it. So understand those categories. So penicillins and cephalosporins, what do they have in common? They're beta lactam drugs. They they attack that they have that beta lactam ring that is able to interfere with peptidoglycan synthesis. So what do bacteria do? They make agents to combat it. Staphylococcus principally targets penicillins with what are called penicillinases. They also make it generically, you would call them all beta lactamases. The ones that are very, very specific to penicillin are penicillinases, and most of the time that's Staphylococcus aureus. Beta lactamases in staph that are not penicillinases are a little bit easier to combat. The trouble is, and that's some of the things we look at that with culture and sensitivity. The reality is that beta lactamases that are produced by other non-staphylococcal, particularly gram negatives, what we call extended spectrum beta lactamases, are a big problem, because those we have it's treating some of these gram negatives like Pseudomonas, like Klebsiella, that cause a lot of problems, particularly in the hospital, are really creating. They're called ESBLs, extended spectrum beta lactamase drugs. So the specific targeting the specific structure, penicillinase, and even beta lactamase. Penicillinase would be the go-to way to describe that. What did they do when it was just beta lactamase producing? We found an agent that's really in the antibiotic category called clavulanic acid. It specifically targets beta lactamase. It's a beta lactamase inhibitor. The whole idea is if you eliminate that from the picture, now it will enhance the effect. So we mixed amoxicillin, a very useful agent that's fairly broad in spectrum, with a beta lactamase inhibitor, clavulanic acid, enhanced its ability, and they gave it a name that talked about its enhancement, augment. You should know that. The most important agents that we use based on number of prescriptions are certainly the cephalosporins. That's approximately half of all antibiotic prescriptions are that. There's a 10% cross reactivity with penicillin with regard to allergies. That's still not wonderful, but it's a lot of people. That means 90% of the people who are allergic to penicillin aren't allergic. You just have to be careful in identifying it. So in the old days, we used to put little droplets in the eye and see if they started to cause it to swell and things like that. So that was one of them. It's broader in spectrum. Inherently, it has better affinity for gram negatives. It is less likely to be activated by beta lactamases. It's bactericidal, just like penicillin, because it's a cell wall antibiotic. So again, the only one in the protein synthesis category are the aminoglycosides, kind of the streptomycin family. The big player in that is gentamicin that we use a lot because it's very useful against Pseudomonas. Bad news, it's not very good for kidneys and hearing. So it's renal toxicity and ototoxicity. So what do we do when somebody's allergic to penicillin and we have to basically pick a lesser agent that's bacteriostatic? That family is called the macrolides. The big player in that is erythromycin. Okay. Nowadays, that still is its family name. Azithromycin is the Z-Pak or Zithromax, whatever the name that's being used for. Because I would assume by this time it's generically available. I don't know. I really don't know. Okay. In the fluoroquinolones category, that's where ciprofloxacin comes from. My wife and I always get into argument whether it's Cipro or Cipro. Folic acid agents, combination sulfas, trimethoprim and sulfonamide, you should know about that. The two big resistance ones that are very, very common today that have caused a lot of problem respiratorily in the nose, MRSA, methicillin-resistant Staphylococcus aureus, and in the gut, more so than C. diff, okay, is because we see it perhaps more in the hospital, we see both of them, and like I said, they play ping pong with one another. One gets one, they get over it, and they get another one because the antibiotics induce one, favor one, and then attack one, but favor the other one from growing. That's called vancomycin-resistant enterococcus. So they're all part of it. The drug of choice for C. diff is that metronidazole. That's a brilliant drug because even though it's an antibiotic that specifically targets anaerobes, and there aren't a lot of players that have good affinity for anaerobes, that's the major usage for something called clindamycin or Cleocin or Clindo. Okay, that's in the categories called lincosamides. They used to do Lincocin. I just had so many side effects. The big problem is it's terrible gastrointestinally, but it's very useful, as you might remember talking about it, penetrating the glycocalyx, which certain agents form around things like orthopedic or metallic hardware internally. I have a lot of experience with that. So that was a sort of a lot. Sometimes it's easy if you put a pin or a screw inside. It's kind of if you take it out, it kind of isn't doing its job. Sometimes you have to. A lot of the pins I used were pins that protruded. Those are a little bit easier to take out if you had to. Interesting that they kind of slide out by themselves when they're ready. Love that. Here it goes. Forms like a little channel around it. So those are other things that are useful for that. But what I was saying is the beauty of metronidazole or Flagyl is that not only does it target anaerobes like C. diff in the bacterial family, it targets anaerobic eukaryotic organisms, and a lot of protozoans are. And so that's why it's useful for amoebic dysentery, because and for giardiasis, which is probably a little bit more common around here. Giardia lambia, I think is the way it pronounces the name. So again, don't use the tetracycline when they got baby teeth. You can't use Vanco against gram negatives. And that brings us kind of into the area tuberculosis drugs at least 6 months or more. At least. And you have to use two because there's so much resistance. We won't, in the next chapter, we will probably look at, but we won't have to remember first or second line drugs. As I'm fond of saying, when you encounter patients with tuberculosis, you do what everybody else does, you look them up. Some of the ones you don't use them as commonly as others. So when we're dealing with, again, protozoan infections, for the most part, you're using metronidazole. The oddball with that is the most common of all the protozoan infections. That's malaria. There are a lot of good anti-malarials. They're starting to change those, as you saw in the PowerPoint. We still use a lot of quinine alkaloid-based products that were really the go-to agents for a long time. But as science moves on, we learn a lot better about it. Again, with regard to antivirals, the one that you surely should know are the acyclovirs. They are so useful. They're nucleoside analogs, and they're particularly useful because they're only activated in cells that have been infected. They're activated by enzymes that are produced by cells that have been infected by herpes. So in that way, there's a lot of selective toxicity. It doesn't mean that that they can't harm you or have other side effects, but it's least likely because all the other agents have an abundance of side effects because somehow, some way, that virus is inside the cell. You have to attack it. And so you have to somehow alter one of the cellular mechanisms that are there. The other one that we get a lot of use for is an exit agent. That's a neuraminidase inhibitor. Tamiflu or Relenza are both in that category, so you don't have to know the trade names that are there. Let's see. Other things that are known for, and definitions of infection. When you hear parasite's an odd term. Parasite is something that occupies you and hurts you, but it thrives. So any type of infectious disease is really true parasitism. I don't make a distinction between mutualism or commensalism. Basically, you're not getting hurt. That's good. That's all I care about. The bacteria lives there. It's okay. It's a good neighbor policy. That's how I deal with my neighbors. If a good neighbor to me is somebody, if somebody's trying to break in the house or it goes on fire, I'll call the appropriate authorities. Other than that, leave me the F alone. It's okay. Come by and pet the dog. I'm terrible. I'm from the good fences make good neighbors school of neighbors. Maybe a little different when your kids are little. So the other thing, when you hear about a parasitic infection, the implication is a eukaryotic pathogen. So we're talking about it in the context of how diseases spread and what makes a disease, okay, why it's nasty. A parasite implies a pathogenic infection, okay? Parasitism, when we talk about parasites more globally, that could be fungal, that could be protozoans, that could be algae. Those are more eukaryotic pathogens, and it's because of the way our immune system responds. That's where eosinophils get busy, by the way, just saying. Okay, when it comes to barriers protecting you, your skin's barrier number one. It's physical, it's chemical, and it's biological. It's strong, it's dry, it's salty, it's acidic, it's got microbes all over the place that are competing for attachment spots. It checks all the boxes. Even the lining cells in your gut, in your mouth, in your respiratory kind of meet the same thing. It's not quite as strong as the skin. So the physical aspect is probably a little bit less, but present. That's those wonderful stratified squamous cells, whether they're keratinizing or non-keratinizing. Normal flora doesn't mean they can't hurt you. Resident microbes, normal bacteria or entities, fungi that are on your skin, given the right circumstances, can damage you. So we call that a compromised host. Again, you just had a test on immune system. If it compromises your immune system, okay, we call that, you're a compromised host or immunologically challenged or immunosuppressed, whatever the terminology is. What does that mean effectively is that even something that shouldn't harm you does harm you. It's like in the lab. We have a BSL-1 type lab, okay? We use agents that don't cause disease or at the very least modified so they don't cause the disease in healthy people. So if someone's immunosuppressed, that's the kind of thing we have to be very, very cautious. Microlab. Who could be easily immunologically suppressed? And we've had students who are pregnant. We've had plenty of those. Okay. For instance, signs and symptoms. How do they do it? Sign, measurable or observable. Pain is a symptom. Okay. Nausea is a symptom. Vomiting is a sign. Okay. All of those types of things. Bleeding is a sign. Okay. Drainage is a sign. Fever is a sign. Okay. Increased heart rate is a sign. Those are things that are observable or measurable in one-way sacred form. Primary versus secondary infections. Primary, it doesn't mean there's an underlying disease like diabetes could be the primary culprit and you can get an infection secondary to it. But typically, if you get a viral infection, then you're predisposed to bacterial pneumonia. The leading reason why people die of influenza and COVID-related problems, bacterial pneumonia. HIV positive people succumb to other infections, bacterial, fungal, etc. Those types of things. So be aware of that. Food poisoning is a primary thing. It's secondary to eating. I'll buy that, but it doesn't mean it. A tetanus infection after you're injured or you stepped on something and didn't get it treated, it's secondary to the event, not that. Okay, so we classify organisms by virulence factors. Is have a low infectious dose? Is it easily spread? Does it harm you greatly? Does it superactivate your immune system? All of those are virulence factors. So the generic term, originally coined by Pasteur to describe virus, meaning a poison, is virulent. So virulent doesn't mean viruses. Virulent can be any microorganisms. Latent infections are important. Classic herpes infections are nearly all latent, particularly the ones we see the most: type 1, type 2 agents, oral and genital herpes, VZV, chickenpox, shingles, varicella zoster viruses. We see those a lot, and they undergo a period of latency. So they hide in sensory nerve roots, okay, and depending on any number of factors, something that compromises your immune system in some way, shape, or form. It's very interesting because it can happen when you're not just sick or not just subsequent to a medicine, but life-changing events. Those are the kinds of things. Accidents, loss of a loved one, the divorces. Those are the kind of things that they work on the inside, and that's one of the tangible evidence to it that are there. So the worst kind of infection is described as called septicemia. It implies that you have infectious particles in your bloodstream and toxins, and that it's making you substantially ill. Okay, bacteremia is something you and I get when we get our teeth scaled. Sometimes when we eat, we get what's called a transient bacteremia. Okay, periodically we get some degree of toxemia from things. There can be transient toxins if you eat something and you just don't have a lot of it and it's not a powerful toxin. You might have it. Okay, so all of those, but the big term is septicemia. That's there. I don't know if I pointed that out. We talked about Koch's postulates. The big thing with Koch and his postulates was that they were based on being able to, and his premise was that you have to be able to identify them in the lab, grow them in pure culture, get them from some infection, grow in pure culture, infect something with that culture that was susceptible to it, and do the whole thing over again. The big problem is a lot of things can't be grown in pure culture more than anything else, and syphilis is still the poster child for that. Syphilis is caused by, and we're going to see that in the next unit, Treponema pallidum. It's there. Everything else you can basically grow in pure culture fairly easily. Okay. And another interesting factor about how diseases are spread is it's remarkable to me that normally it's how they enter is how they exit, the damage they do. When we get the flu, what do? We cough. We get COVID, what do? We cough. Okay, we get food infections, what do they cause diarrhea. Okay, and so it's easy to spread, it's harder to do hand care, etc. Gets on surfaces. So frequently things that come off your skin diseases, little flakes, it's easier for you to come in contact with them, etc. Like that. Let's see. One, I don't know if we made a big point out of this. It's on the exam, so I want to give it to you for the sake of completeness. They're called AB toxins. Okay. A is the active, most toxins, tetanus, diphtheria, pertussis that we're going to get to. The AB toxin, and it's interesting because we use them for research. B is a binding agent. A is the active agent that does the damage. they're made by whatever the organism is as a unit. The B part binds and the A part enters. So what we're doing is we're utilizing the B part, which really doesn't harm you, as maybe a vehicle to bring therapeutic agents like the cancer cells because they attach to certain cells. So I don't know if I made a point of that, but I should, because I don't think it was well stated in the Cowan text. And the other one that wasn't probably uh, stated so much is something called a super antigen. I don't know whether you cover this in immune. I usually do. What is a super antigen? Super antigens, and we're going to look at those in toxic shock. We're going to look at them in scarlet fever. We're going to look at them in necrotizing fasciitis as we conclude the term, which thankfully is upon us. Won't see you again. I'm not being mean. I have a new bunch. I won't even be teaching this stuff anymore. What it is it super activates about 20% of your helper T cells. If you remember from your immune unit, they make a bunch of what are called cytokines. You get what's called a cytokine storm. It causes your immune system to go crazy, and in itself, it's potentially lethal because when all of those cytokines, they dilate blood vessels, they lead to shock. That's when we get the term toxic shock that we'll talk about. That is very, very interesting. Because I mean, I was just started in practice when that all of a sudden we had effectively an epidemic from that back in 1980 that was caused by, are you ready? Tampons. Now we see it more in wound infections that are there. So that's a big player. And so to summarize it, when bacteria, you can have, there's almost all of them, whether it's toxins, whether it's antigen antibody complexes, whether it's antibodies, immobilized antibodies that actually attack you, which happens, or of that type of inflammatory storm. There's so many ways. So typically infections can attack you both directly and indirectly with some degree of frequency. I did put in something about morbidity and mortality studies. Again, morbidity is the number of people sick, mortality is the number of people who die. Okay, so it doesn't indicate that morbidity, again, just like an epidemic, you could have an epidemic of the common cold, not going to kill you, or you could have an epidemic of HIV, which certainly could kill you if it's untreated. So it doesn't speak to it being life threatening or anything along the lines. It just speaks to the fact that you are infected or diseased in some way, shape, or form. The hardest way to get rid of diseases in our environment is in the food, is in inanimate supplies. Humans and animals. Humans we can quarantine. Animals we can deal with animal control. Okay, but food and water supply, very, very prominent, and soil and water supply, very much of a problem. Okay, so if you're in, and many of you are going to be facing this, you have to be cautious, particularly with somebody who is infected, because you can directly get a disease from contacting somebody with a blood spray. You're trying to do a blood draw or do a treatment, and all of a sudden somebody spits on you, coughs on you. You know, you can get a blood spatter. My first wife got one of those. That was subsequently how they had identified that she had hepatitis C. I don't think she got it from that. And once again, nosocomial infection, something you're going to be very familiar with. Hospital-related or hospital-induced is technically what it means. Again, still predominate in the urinary tract. And I think that's just about everything. With regard to HIV, understand that when we treat that with antivirals, we have multiple. We use the nucleotide analog, or what they call nucleoside analogs, reverse transcriptase inhibitors, entry inhibitors, protease inhibitors. They're all part. So when you hear those, that's the one, again, most of our antivirals are either for herpes, influenza, or HIV. The other ones were just kind of working. They're starting to get more for hepatitis C, etc. And that's it. You're good. Happy dance. Who knew? End of the review. Moving on. So, what happens next I might as well just show you. I'll just do a little mini introduction in the few minutes we have left. There's new happening there. Yeah. Come on, light up. I see light. So I started to scroll through this. And you'll see it here. Here's one I didn't even know about. That's a good thing about getting a different textbook that's more updated. That's there that I heard because I'm out of the loop. This is a, they're seeing this in children's throat and in adult throat infections, this Fusobacterium necrophorum. And I mean, sometimes people are just minor. It's a gram-negative rod. And sometimes I actually Googled an article just before we get started. Look at this. This is a scientific article about emerging pathogen of otogenic and paranasal infections. I mean, they just study 5 cases there, and whatever they said in the abstract, like 3 of them died. Terrible. 9-year-old healthy girl with fever, headache, and a lot of them they're sort of manifesting itself like bacterial meningitis, which I think would be the differential. You get bacterial meningitis from the weakness of the blood-brain barrier in your upper respiratory area. And so it's cerebrospinal fluid, neutrophilic pleocytosis. So cells were going away. They used cephalosporin, CT scans, total obliteration of the right mastoid, because mastoiditis, that's a mastoid. There's a sinus in there, not paranasal, but behind here. Oh, unbelievable. So gram-negative rods, and usually the go-to you think of in children, Haemophilus influenza, which we'll talk about. Their autopsy. Well, now you know what that tells you. The person died. 9-year-old girl. Awful. 24 hours after admission. Let me acquaint you with rule number 1. When you're in a hospital or in your healthcare, people die. Rule number 2, there's doctors and nurses can't eliminate rule number 1. All you can do is do your best. Understand that you have to, wherever you're going to be doing, you come up with it. I worked in a field that had a very limited, but not non-existent death factor. I had a lot of diabetics. Diabetics die of infections. So just throwing it out there for everybody. So I went back. So I started to scroll through this particular PowerPoint. I had some of the stuff that we talked about already. I figure I'd just introduce it in a couple of minutes we have left. And talk what we talked about. The arrangement here, they put the larynx in upper. Remember I was talking about that. And I don't know if they went into all the anatomical stuff that's so interesting. That's there, the mucociliary escalator and all that with regard to your defenses, nasal hair, cilia, mucus, other defensive things, antimicrobials, inherent cytokines, macrophages, good old secretory IgA, the A in MAG of that, which is a lot of secretions. Okay. And then, as you can see, an abundance of normal microbes. We're starting to learn more about certain low levels. We used to think that this was free of microbes. You have tons of macrophages. They're like little sweepers that you expel all the time. Okay. Millions of them on a daily basis that are there for that. So thousands of commensal organisms that are just there. Look at these. And it's not that they don't cause disease. Strep pyogenes, strep throat. I just talked about it. Haemophilus influenza was named because most of us have it. They thought it was the cause of the dreaded Spanish flu. And that's why they named it. Okay. It grew with blood agar, Haemophilus, it liked blood, and influenza because they thought it was, and it turned out nothing to do with it. But it's the leading cause of bacterial meningitis in infants and a leading cause in children of sinus, ear, conjunctivitis infections, as is its cousin there, Streptococcus pneumonia, which is a gram-positive rod that, again, you probably talked about a bit in the lab. These two are the big players for otitis media, sinusitis, and conjunctivitis. I like this text doesn't look at they consider the conjunctivitis a skin disease. Okay, I'm not making an issue out of it. Okay, but to me, it's not. It can be, but it's not. I don't think. Neisseria meningitis, which some people harbor, good old Staph aureus. About a third to half of us have candida in our mouth. Nothing unusual about that. It's different in people with respiratory diseases, smokers versus non-smokers. That's interesting. Okay, so chances of pathogens establish itself by competing for resources in space. That's what normal microbes do. There's a limited number of spots to land on, and there's a limited number of nutrients that are there. There you are. Good old pharyngitis, sore throat. That's all it means. Doesn't mean if it says streptococcus pharyngitis, it's a strep throat. Pain, inflamed, reddened, or swollen. Okay. Bacteria typically are much more problematic. The big distinction between viral and bacteria infections, okay? Viral infections, mild ones like the cold, don't typically have accompanied with fever, headache, nausea, okay? Like that. So when we start to get bacterial, we get a little bit more. Fever is more common, gland swelling is more common, severe sore throat. Not exclusively. You're going to learn about adenoviruses, which are kind of like when you hear about the bad cold. That's where they come from. Okay, mechanical irritation. Okay, all these different types of things. So that can cause it. Pharyngitis caused by most serious again, Group A beta hemolytic streptococcus biology. So we'll talk about strep throat at length. Gram-positive cocci, typically in pairs or in chains. You might remember from early days, they replicate in one plane and say they're non-endospore formers. They don't move around. They do form capsules and slime layers. They are a facultative anaerobe. That's that bubble test again. They don't make catalase. So they make enough probably superoxide dismutase and this peroxidase to allow for its survival in the presence of oxygen. But they're catalase negative, and that's the bubble test. Yeah. The biggest single problem with streptococcus, your throat's going to get better. It's on the surface. It has to do with the immunological infection. Every so often you get a very, very severe one. These days we treat them very promptly because we have able means to identify them. We have the early test. Physicians are in tune with it. If they see something that looks suspicious, they're going to take a culture. They're going to do a rapid strep test. Okay, these are some of the things. There's a limited number of strains that do things that have problems. One is called erythrogenic toxin because it makes your skin look red. Scarlet fever. Sandpaper rash with high fever, extremely high fatality rates. And then the immunologic aspect, you're going to learn about rheumatic fever, immunologic cross reaction between certain proteins, and not just heart, but the lining of the heart and the heart valves, and the linings are joints. That's where the name rheumatic comes from, because it's heart related and arthritic related. It's a common, we don't see it that much. But if it's not picked up, that's why you tend to treat those a little more aggressively with antibiotics. It doesn't mean it's not going to happen. That's there. That's another one. The toxic shock syndrome. We see that more with streptococcal wound infections now than anything else. It's just sort of scratching the surfaces. There are a lot of problems with this. Another one that happens is that the antibodies that you and I form to certain strains of streptococcus form big clumps called antigen antibody complexes. They have a nasty habit of going into your kidney and clogging it up. Did you do kidney yet? A&P? Some did, some didn't. The glomerulus gets clogged with these, okay? And it can't filter. And the kidney has one response to not working. It shuts down. We'll leave it at that. It's called acute glomerulonephritis. We see more common with streptococcal skin infections, but it can happen with strep throat. It happened to my stepson when he was in high school. Just saying. All right. Have a great weekend. Monday, I will send you soon, today, about this exam that we're doing online. I created the login. I created a password. And I think you can take it between 8:30 and 10:30. It's the login time. But once you start, you have an hour to do it. Happy dance. Right? And I'll give you all the information. Again, if you need to contact me, text. I don't want to talk to you. I shouldn't say that.